Single-payer healthcare, the salvation of our healthcare system, providing quality, affordable, abundant healthcare to all, or an expensive way to kill healthcare innovation while busting our deficit. Our experts today debate this important and timely issue as we see which way the U.S. healthcare system is headed on today's edition of Debating Health.
Doctor, please, don't you know I'm going fast?
Welcome to this edition of Debating Health. I'm your host, Scott Ehrlich. With insurers dropping from the exchanges in high numbers, and with the likelihood of more to come next year, it appears the ACA in its current form has a limited lifespan left. Meanwhile, Republican attempts to replace it with a healthcare plan more to their liking failed even harder, with no consensus emerging on a replacement other than a watered-down version of the bill that they were trying to replace. So with the door open to a new healthcare plan, yet the widespread desire of the American populace to now have government provide some sort of health coverage, is the time right for single-payer in this country? After all, industrialized nations all over the world have some form of single-payer healthcare, allowing people to pay for their healthcare insurance through the taxation and not at the point of care. Proponents say the system is cheaper, fairer, provides better health benefits, and more widespread access. Yet nowhere in the United States has it been successfully implemented, with cost the deterrent thus far in places that have pushed for it, such as California, New York, and Vermont, after studies have shown that implementing such a plan would cost several multiples of their total current state budgets. Cost is not the only downside of single payer, as opponents have cited long wait times, loss of coverage, and providers suited to the needs of patients, and a lack of development and implementation of new drugs and treatments under a single payer plan. So is this a direction the United States should move in? Or does single payer provide more cost and less benefit than its devotees let on? Let's debate this on today's edition of Debating Health.
Hit me with your best shot. Come on, hit me with your best shot.
Our first guest is John Davidson, Senior Editor at the Federalist and Senior Fellow at the Texas Public Policy Foundation, who thinks single payer is the wrong way to go. John, thank you so much for joining us.
Thanks for having me.
So, John, I wanted to talk to you a little bit about single payer healthcare, and I know you're not really an advocate. I think you're a fairly staunch opponent, and that's kind of what I wanted to chat with you about here today. So I think one thing that always shapes the debate or people always push is that single payer is this, single payer is that. What is single payer? I mean, it means different things in different countries and different things to different people. So let's start that out by saying, what does single payer actually mean to you?
Sure. It's a good question, and it does mean different things in different countries that have, come up with various iterations of single payer. But I think for the purposes of debating it in this country, what we mean by single payer is the government is the only payer of healthcare. Right now, we have insurance companies and a mix of state and federal programs that pay for people's healthcare, and only a little bit of our healthcare is paid for out of pocket by us. So employers are big payers in healthcare. If you get a job with a big corporation and they offer health insurance benefits, a huge chunk of your compensation that you never see in your paycheck is actually going to an insurance company to pay for your premium, your monthly premium, and to pay medical claims on that insurance plan. So when we say single payer healthcare here, we mean that we would get rid of all that private health insurance stuff, and we would consolidate all of the state and federal health insurance programs into a single government program where the government would pay the healthcare providers to provide care. That's sort of how Medicaid works, the healthcare program for low-income, elderly, and disabled folks and pregnant women and children, and then, of course, the Medicaid expansion through the Affordable Care Act. That's a kind of single-payer system. So is Medicare. And so that's what we mean, I think, for the purposes of debate in this country.
So when you say that, would you be talking about something, I guess, more akin to Medicare, where it doesn't pick up everything, or you can get supplemental policies or policies like they have in certain countries where you cannot get a private policy, or for purposes of debate, does that not really matter?
Yeah, I mean, well, the devil's in the details, right? So
Absolutely.
It depends on what Bernie Sanders and, his crew think in their mind when they talk about free healthcare or single payer healthcare. Do they mean like a system like, Cuba and North Korea, where there's only one way to get healthcare, and that's through the government, like hospital and the government clinics, or something more like France, where you have sort of a national system of government paid health care. But then if you can afford it, you can buy, private insurance plans. You can go see private doctors. There's any number of private arrangements you can make if you can afford it.
I heard you mention France there, and I keep hearing when I talk to people on this issue, they say that every first world country or industrialized country in the world has single payer. They made it work except the U.S. Well, why don't we have single payer health care? And what is it that we do differently, or why is it different here? And why can't we do it here?
Well, there's a very long story of how we got the healthcare system that we have.
Yeah, no one would design this system from scratch.
No, right. It's sort of all been sort of by accident, right? The reason, for instance, that employers provide so much healthcare in this country, there's really not a good reason. It's not like somebody planned it out. It came from price controls during World War II. A lot of employers found that it was hard to attract employees and keep employees in certain jobs because they couldn't offer them, the commensurate salaries for what they were actually worth. So what they would do instead is give them different kinds of benefits. And one of those benefits was health insurance plans. And by the early 1950s, the IRS had started treating those as tax exempt. That was codified into law. And so suddenly you have a huge incentive for employers to divert a lot of compensation into these tax-free health insurance plans. And so that's how we got this sort of accident from World War II. The reason we don't have single-payer healthcare in this country, though, is because the interests have never really aligned for the major players in our healthcare system to have it. One of the reasons the Affordable Care Act was passed is because the Obama administration and congressional Democrats were able to make the incentives align, or at least make them seem like they would align for the major insurance companies and hospital systems to say, hey, we're going to add, 20, 30 million people to your insurance rolls. You're going to make a lot of money off of this. All you have to do is sort of play ball. And I think they thought it would work, and so that's why they endorsed it. When they first passed Medicare, back in 1965, and the entire debate leading up to that, the American Medical Association, which at that time was sort of one of the big special interest groups in the healthcare world, was staunchly against it. They decried it, said this is the socializing healthcare. And they were, in the end, unsuccessful in their efforts to lobby against it. So that's a long answer to an even longer. It's a short answer to an even longer question. Sure. There's a lot of reasons we don't have single-payer healthcare in this country, but one of them is that the system we have is sort of a series of historical accidents.
But what are those other countries doing, or what do they have that we don't have? I mean, again, why can't we have it, or what are they doing that's different than here that makes it so hard to get here?
Yeah, I mean, part of it, Bernie Sanders and the Democrats always talk about, the Scandinavian countries. Sure. And in a resource-rich country like Norway that has 4 or 5 million people, it's relatively easy to come up with any kind of welfare program, whether it's healthcare or a housing subsidy that covers everybody. We've got 325 million people, and so the math is different for us here. It's not a simple matter of just creating a benefit, right? The price tag. So one thing is the price tag is much higher here because of our population. The other thing is that these other countries, they don't all have the same kind of system. In Switzerland, for instance, you have a kind of Obamacare type system where you have private insurance companies selling on exchanges. But the difference, of course, is that the exchanges are far less regulated than the Obamacare exchanges, and the subsidies are actually enough to allow a big chunk of the middle class to purchase health insurance plans, and people actually like it there. And a lot of healthcare wonks, Ovik Roy comes to mind, have argued that we should transform Obamacare into a Switzerland-like system, keeping the exchanges and keeping that market mechanism, but actually making it work like a market. So there's different iterations that sort of along the spectrum of how you could have government involvement in healthcare. And one of the things that we get tripped up on in our debate in this country is that there's this false dichotomy that before the Affordable Care Act we had a free market healthcare. Well, that's not true. We've never had free market healthcare. As we discussed, since the end of World War II, we've had major government intervention in our healthcare system, not only with the tax exemption for employer-sponsored sponsored plans, but also through Medicare. A lot of hospitals, more than 50% of their revenue comes from Medicare. Well, at that point, that's more or less a government hospital that is reliant on the Centers for Medicare and Medicaid Services to keep their doors open.
You mentioned, going back a little bit, you mentioned in Norway, it's 4 or 5 million people. That's what, slightly more than 1% of the U.S. population, and how much easier it is to cover people or population of that size. Norway is obviously a lot more homogeneous in terms of its population's demographics, etc. But they've tried to do that in Vermont here and pulled away from single payer, even Vermont, which is considerably smaller than even Norway. Do you know anything about that, or can you tell a little bit about why that happened?
Yeah, Vermont was, had this idea that it would winnow down the number of insurers that it was going to sort of license to offer plans in Vermont, and eventually it would have no insurance companies. We actually had at the Texas Public Policy Foundation, the chairman of the House Committee on Public Health, who was one of the architects of this plan, come to one of our conferences and explain their entire scheme. And I remember somebody in the audience asking, hold on now, so what you're saying is that when you get to the end of this 5-year process, it'll be illegal for health insurance companies to sell plans in Vermont. Is that what you're saying? And of course, he had to say, yes, that's what I'm saying. So it was a radical idea, and I think as they got further down the road, they realized that the tax increase that would be required to do this would simply be too much, and the voters would sort of revolt at the price tag, sort of the sticker shock. Yeah. And in fact, something similar just happened. Well, it hasn't happened yet, but it will if they take it to the voters in California, where they realized it would cost, twice the state budget, something like $400 billion.
Yeah, staggering numbers I saw. Yeah, but I'm curious though, and again, I think that brings me back to the point that supporters push for single payer is, well, why does it cost so much? I know I've heard figures as to about $10,000 per person here to provide healthcare versus something like $5,000 in some European countries. Why is it so much more expensive to provide healthcare in this country versus those countries?
Yeah, that's a great question. And this is the thing, this really gets down into brass tacks and gets into like the uncomfortable realities that people don't really want to talk about, or that are hard to talk about because this is sort of behind the curtain, right, of the healthcare world. The reason healthcare costs more in the United States is because doctors and hospitals and people who work in the healthcare industry, including hospital administrators, make a lot more money than those people do in other countries. If you look at what doctors make in Europe or in Australia or other developed parts of the world, they don't make anywhere near what doctors make here. And it's not just doctors. The growth in hospital administration is akin to the growth of the administrative parts of our higher education system. When you've seen these charts saying over the past 40 years, the number of administrators has increased by 400%, and the number of professors and faculty has remained more or less the same. Like, well, what are all those administrators doing? Well, it's something similar is happening in healthcare. These giant hospital systems are gobbling up independent doctors' practices and independent freestanding clinics, and rather than adding to the ranks of medical teams like nurse practitioners and specialists and other supportive staff, they hire administrators that make a lot of money. In some cases, the administrators make as much as the physicians, and they divert a lot of the nonprofit hospitals are also diverting those profits into building programs. We talk about a healthcare crisis in this country, and the healthcare costs so much. And why does it cost so much? Well, drive by a major hospital sometime and count the number of cranes that you see outside. Here in Texas, you go to Dallas, Parkland Hospital in Dallas. That's a nonprofit. It's supposed to be a public hospital. And it's like a space station. They just finished doing a huge addition to it. That's where the money is going. The money is going into major hospital systems and hospital administrators, and going to pay very high salaries for doctors. And that's an uncomfortable thing to talk about, because we say, well, how do we bring the healthcare costs down? Well, pay doctors less.
So what would need to happen, you think, to move in that direction? Do you think we would just have to change the way our entire medical education system is done? Do you think we would just have to do with kind of lesser facilities or lesser support staff? Or is there a way to bring down cost into some kind of parity that is politically feasible, even if it's a stretch?
Yeah, I think there is, and I should mention one other thing aside from the cost of paying hospital administrators and paying for these palatial hospitals. The other thing is Americans tend to consume more healthcare than they should. So we get too many tests, right? We get the doctors, and part of that is we have a litigious culture in the medical world. So doctors are over testing and over prescribing and authorizing procedures and treatments for people at the very end of their life. The vast majority of the healthcare that any American consumes is in the last year or so of their life, and the incentives there are all wrong. The reason a lot of hospitals and doctors do this is because for very elderly folks, there's a payer for those procedures. Medicare will pay for it. And so we have to start thinking about how can we be smarter about how we use healthcare, and how can we think again about how we pay for healthcare and where those payments go. Does that mean we have to look at how we structure the nonprofit aspects of the hospital? There's a lot of oversight that's not really there, that's there on paper, but if you dig into the sort of IRS 990 forms of these hospitals, you realize they're not being entirely honest about their financial situation, A, and B, they're making money hand over fist. So we need to have that needs to be part of the conversation about healthcare. And unfortunately, with Obamacare, it was all about coverage, and we didn't talk anything really about cost. But cost is where it's at. If you can bring costs down, then healthcare becomes more attainable for more Americans. It can become more like a consumer product. But it's not right now.
So final question. Say in 2020, the Trump effect, negative effects are real. Democrats take back all three branches of government. President Sanders or President Warren or President Jerry Brown or whichever Democrat you want to choose is able to push through single-payer health care in terms of whatever fashion they're able to get through. You can pick your system of choice to decide exactly what the mechanics of that would be. What would our healthcare system look like? What would the positives and negatives coming out of that be? And where would you see that taking our healthcare system in the next 10 years?
Well, it's a wild guess because there's so many variables, but I would think that if Democrats had their druthers, they would impose some sort of expansion of Medicaid combined with an expansion of Medicare. They would kind of build on the existing healthcare entitlements that we have. That would be the logical thing to do. Those would come with a lot of rules and regulations from the federal level coming down to the states. In the case of Medicaid, already states have very little control over their Medicaid programs, which is by design. And then you would have an expansion of the franchise of Medicare. And I think you would have a lot of people be dissatisfied with that very quickly. Since
why would that be? Would that change quality of care? Would that change research cost? What is the big reason? I mean, like I said, I had you on here because I know you're not really you're against single payer. Why? Boil that down to what that's going to do to the healthcare system in your opinion.
Let me build off the answer to the question about expanding Medicaid and Medicare. You would see the problems that you have in Medicaid and Medicare extrapolated out to the population at large. Right now, 85% of Americans get their health insurance through their employer. Not everybody's thrilled with it, but it is a benefit that people find as valuable. That's why they didn't do it. That's why the Democrats didn't really touch the employer-provided health care, because they didn't want any of those people to lose their coverage. They didn't want to mess with that.
If you like your doctor, you can keep it, right? Yeah.
Yeah, right. And people who work for a large employer who has a health care plan, those people, most of them did keep their plans. Maybe they had to pay a little bit more, more employee contribution, but they have coverage through their employer and they like it and they want to keep it, mostly because it shields them from the true cost of their care. But that's another issue. But if you put all of those people into a Medicaid or Medicare type system, they are going to discover, to their dismay, the failures and the shortcomings of those systems that the people who are on it and who have been on it for years experience all the time. And those are primarily shortages and rationing of care. The reason that people on Medicaid have worse health outcomes is in many cases they don't have access to physicians when they need them. They end up going to the emergency room for routine care because they don't have a doctor. They can't find a doctor. They can't find a specialist who participates in the Medicaid program. And the reason for that is that Medicaid doesn't pay enough. It's too bureaucratic. It's a sort of a pain in the neck for a lot of doctors to participate in. So they would rather just provide charity care on their own terms rather than even participate in the Medicaid program. But what that does is create shortages. It creates rationing of care. You see the same thing in Medicare. A lot of people have to have supplemental plans because the Medicare doesn't cover everything they need. And so you would see that sort of on a national scale. And I think people who have kind of gone through their lives ignoring Medicare because they're not over 65 yet, or ignoring Medicaid because they're not poor, would suddenly realize that these programs that they hear about in the Obamacare debate have major shortcomings, and they would come to feel those in a really personal way. And so I think it would not be too long before voters were demanding something else.
So you or I break a leg or we get a cold, how would our care change under a single payer system?
One of the things that I think you would be likely to see here is what you see in other countries that have a kind of government single payer. You'd see a lot more waiting time. That's what you have in Canada. A lot of Canadians come over here to the United States for certain procedures because the waiting time is just too long there. In Britain, you see people who will get that supplemental care or that will engage in medical tourism to get needed procedures because of the waiting time, because there's just not enough providers to do what they need. I don't think it would be very long. In fact, I think it would be seamless that we would have a kind of industry that would rise up here that would supplement medical care for those who could afford it. And so you would have I think you would end one of the things you would end up with is an even more stratified healthcare system than we have now, where those with means had access to a private sort of tier of care, and everybody else was herded into this public system that has long waiting times, that maybe has a lower quality of care and lower standards, and maybe fewer options for people as well.
So in your opinion, a true single payer is really impossible because money is mobile, and people with money would find a way to get better care than people without it, no matter what sort of regulations or taxes we were to propose.
Yeah, like I said earlier, the only true single payer is in Cuba and North Korea. So, markets arise where there is money and there's demand, and so there would be some kind of market here. It would just probably be a much more constricted one than we have now.
So less care, higher taxes, less technology. You think would be a real view of what single payer would look like in the United States?
Definitely, there would be rationing of care, and the tax bill would be astronomical. The other thing you have to consider is that the folks who are making very good money off the healthcare system right now, that I mentioned earlier, they're not going to want to take a haircut for single payer. So that's going to cost the American taxpayers a boatload of money, as we've seen. We mentioned Vermont and California. There's a reason it costs $400 billion to bring single payer to California. If you paid all those doctors, like you pay sort of a low-level government bureaucrat, maybe it wouldn't cost so much. But I doubt that those doctors would stay in this country.
Sure. Is there any winners in a single-payer system if we were to put it into place in the United States? Would anyone be better off?
Yeah, I mean, in a system this vast and in a country this diverse, there's always going to be people who benefit from a new entitlement or the expansion of an entitlement. So those that with no access to health insurance right now would benefit.
But who would those be at this point? Because between Medicaid, Medicare, it doesn't seem like anyone would really have no access, a guaranteed issue that there would really be any people at this point with no access.
Yeah, I mean, there's tens of millions of people who are uninsured still in this country, despite the claims of Democrats and Obamacare. A lot of people they don't feel that it's worth it to buy health insurance, right?
But that's different than no access, correct? Not having insurance.
Yeah, right. That is different. Everyone can go to the emergency room, for example. Everyone can go to a walk-in clinic. If you have money, you can get on a payment plan for, and get a procedure that you need. I think the winners in a single payer system would be those people who maybe need care and want care, but they don't feel like they can afford it. They don't feel like they can pay out of pocket, or they don't want to pay out of pocket. And there's plenty of people like that, especially young people make decisions all the time about whether or not they want to pay, $600 a month for insurance, or whether they want to pay for, prescription drugs or physical therapy, or to get this procedure or that procedure done that their physician says they need to get done. And they just don't do it because there's other things to spend money on.
Sure.
So that's going to be a factor in any kind of expansion of entitlement, and we saw that with the Medicaid expansion. That was a little bit of a glimpse into what expanding the healthcare as an entitlement would look like. Almost all the gains from Obamacare came from the expansion of Medicaid, not the availability of tax credits to purchase private plans.
And have there been any studies to show that there's been any health benefit from that expansion of Medicaid?
The studies that we do have that compare, people on Medicaid to people of a similar income category who are not on Medicaid don't show any difference in health outcomes between the two groups. So in other words, being on Medicaid doesn't make you healthier than not being on Medicaid, but it does make you more likely to go to the emergency room, and it does make you feel more financially secure. Those are the two things that studies have found, that the most well-known of which is the Oregon study that was actually a controlled study that looked at two randomly chosen groups of people that were both eligible for that state's Medicaid expansion, and they didn't find any measurable medical differences between the health outcomes of these two groups.
Is there any final thing you'd like to say as to why we should not move towards the single-payer system in the United States?
This maybe is a little bit beyond the scope of just the strict discussion about single payer, but one of the main reasons to not have single payer is that there's another sort of possible future for healthcare in America, and that is to make, and I alluded to this earlier, that is to make healthcare more like a retail commodity, to bring the price down, to make it a truly market-driven product that is bought and sold. If we make it single payer, that will never happen. But if we start treating healthcare like it's something that is bought and sold, that's something, health insurance could be something that people own individually and personally, that a relationship between a patient and a doctor doesn't have to be mediated by an insurance company, prices would go way down. And there's evidence of this in small experiments in care that have been happening in recent years all over the country. Radical reductions in the cost of care, even for complex surgical procedures. That's possible. We can make healthcare affordable to more people and expand access to care by making it more affordable. How do you make it more affordable? By bringing real competition in. And the entrenched interests in our healthcare system today do not want more competition. They would rather collude with the government in expanding these entitlements and trying to guarantee a certain slice of the pie for themselves and actually compete on quality and price. So that's I think the most compelling argument against single payer is what we miss out on, in terms of what we could have if we go with a market-based competitive system.
John, thank you so much. Really appreciate you taking the time.
All right. Thank you. My pleasure.
Our second guest is Dr. Carol Paris, president of Physicians for a National Health Plan, an organization pushing for single payer in the United States. Dr. Paris, thanks for joining me.
My pleasure, Scott.
Dr. Paris, why single payer?
Single payer because we have tried to make the private insurance industry work in this country, and it has worked in other countries where it is highly regulated, but we have not been successful in regulating it in this country, and without that kind of regulation, the cost of health care in this country is skyrocketing, and that is why we need to go with single payer. We can save $500 billion every year by simply eliminating the administrative waste and profit of the insurance industry. And that's money that can care for people who are currently without insurance.
Now, you said insurance isn't working in this country, but I'm pretty sure that the polls I saw before ACA was passed said something like 80-something% of people were satisfied with their insurance plans.
Well, I would look at the polls now. 62% of people actually favor a national health program. Before the ACA, the cost of health insurance of insurance premiums were going up. Co-pays were going up, deductibles were going up. The Affordable Care Act not only didn't help to improve that, but it made it worse. Co-pays went up even more, deductibles went up even more, and premiums are going up in double digits.
No argument there.
So the Affordable Care Act has failed to lower the cost of purchasing insurance.
Why don't you define single payer for us in terms of how you see it? Because I know some people use single payer for a whole bunch of different systems that are actually very different in practice. So I guess why don't you define single payer as you see it?
Yeah. The way that PNHP uses the term single payer is synonymous with improved and expanded Medicare for all. And it's very important to say improved Medicare because our current Medicare program has co-pays and deductibles and premiums and all kinds of barriers to care. So we're not talking about expanding that Medicare to everyone in the country. We're talking about using our traditional Medicare as the model, but improving it and expanding it to everyone from birth to death. The reason, and this is only talking about how we finance health care. This is not talking about the delivery of health care.
Sure.
So when I heard Senator Gaines refer to single payer Medicare for all as socialized medicine, that's simply incorrect. England has socialized medicine, and that means that both the financing and the delivery of care is under the government's jurisdiction. So what we're talking about is leaving our delivery alone. We have private delivery of care. We have people who are employed physicians. We have people who work for the VA. We're not talking about changing that. We're only talking about taking our fragmented multi-payer system and taking out the waste that comes from that kind of fragmentation and putting it to better use, which is actually putting it to use delivering care instead of delivering administrative waste and profit to an insurance industry that simply has outlived its usefulness to the American people. That happens all the time. I mean, Blockbuster outlived its usefulness. We don't buy and rent videos anymore. We've moved on. And it's time to just move on from the insurance industry. It serves no useful purpose anymore.
Well, I'd argue with that it serves a very good purpose in terms of allowing different people different levels of health care at different prices. I mean, I have a catastrophic plan, for example, because I'm younger and don't get sick as much. And if I figure, why should I pay the same rates as someone that's 60 years old and is seeing the doctors all the time when I could get a plan that's much more customized to my needs?
What are you going to do as a young man who, statistically, it's young men who are most likely to develop testicular cancer? Now, have you already planned that you're not going to get testicular cancer?
But I got diabetes under my insurance, and my insurance covers everything over a certain amount. I did plan for that. I mean, that's just financial planning. So even if I got testicular cancer tomorrow, I'm still covered over anything over a certain deductible rate, and I'm fully fine with that.
I'm happy for you that you have the financial resources and wherewithal to assimilate that kind of expense. But I think that the majority of working class Americans really don't have that kind of savings. They are going to be put in financial distress with a medical bill of $500.
But then wouldn't they also be in medical distress paying premiums or paying increased taxes necessary to fund something like this?
Well, I'm really glad that you asked that. With the kind of progressive taxation that is outlined in H.R. 676, which is Congressman Conyers' single-payer Medicare for All bill, your taxation is based on your income. And so if you don't make a lot of money, you don't pay a lot of tax. And if you make more money, you pay more in tax. It's a way of redistributing wealth in such a way that everyone
Well, wait,
is able to be
didn't you just
covered
criticize
and get health care.
Senator Dane for saying that this was a socialist healthcare system, and now you said that exactly how to fund it would be the exact principle of a socialist healthcare system, which is taking wealth and then redistributing it?
Well, I don't agree with you. We take our tax dollars and we decide how we're going to use those tax dollars all the time. And I'm saying that we make a decision to redistribute that money, whether we're going to distribute it to the war machine or to the health and welfare of our citizens.
What
is our decision.
Well, how is this going to, under your plan, how will this affect doctor pay?
In this plan, if you look at the income of Canadian physicians, it's actually quite competitive. And I would say that the majority of physicians would make as much, possibly even more money than they're making now. And there are a few specialists who would probably make less. Specialties that are very heavily procedure-oriented, like vascular surgeons and orthopedic surgeons. They may make less money, but they also will have an improved quality of life and they will make money on streamlining their administrative costs.
Go back.
At the office level.
How will they have an improved quality of life while making less money?
Oh, you think that having more money makes your life better?
Well, I'm just saying, if they want to make less money, they could do it right now, but most of them choose not to. So by forcing them to make less money under your plan, you're saying that that's suddenly going to make their life better when they could do that on their own without your plan.
Okay.
I'm just saying nothing stops them from making more money if you think that's a way to improve. I'm just saying, how are you going to incentivize people to be specialists and doctors if their income and their incentives are taken away?
We're actually incentivizing people to become primary care providers and for less of our physician workforce, to become specialists. Right now, the reason so many young physicians go into specialty and subspecialty programs is because they come out of medical school with $300,000 or more in medical school debt. So that's actually another aspect of the legislation that we propose, and that is to pay for medical education so that doctors can actually go into medicine to take care of patients and not have to go into high-paying specialties just to pay off their medical school debt.
Well, 2 points on that. Firstly,
and that works very well in lots of other countries. I worked for a year in New Zealand where the majority of physicians are primary care providers.
Firstly, haven't subsidizing education caused education prices to skyrocket in this country ever since we've started subsidizing undergraduate education? Doing that in healthcare, do the exact same thing and cost us a fortune as a society?
I don't have any particular statistics on that. I know that in the state of Tennessee, where I live, our governor, our Republican governor and legislature has made the decision to make post-secondary education at schools in Tennessee free because they want an educated workforce that lives in the state.
It's got to come out of tax dollars, so it's got to come from somewhere. Nothing is free.
No, right. It's how we choose to use our tax dollars, and I think that is a discussion that we need to have. I happen to think that it's in my best interest for you to have good health care and for everyone in this country to have good health care. Because when everyone has good health care, first of all, from a public health standpoint, I'm not being exposed to tuberculosis and other kinds of infectious diseases.
Well, I can't remember the last.
Untreated.
Well, we haven't had single payer here for years, and I can't remember many tuberculosis outbreaks that have occurred in the United States.
Well, you don't live in Chicago or Detroit then.
Isn't it largely immigrant populations bringing those in?
So from a public health standpoint, we have it's beneficial, and also from the standpoint of how we use our tax dollars. I would rather have my tax dollars going towards the provision of health care than going towards CEO salaries for private insurance executives.
Aren't there charitable ways where you could do that on your own and put as many of your dollars into any sort of healthcare organization as you wish? I know we donate to the Children's Hospital of Atlanta every year.
Well, I think that's wonderful that you donate, and I think that the American people are generous people. But I don't think that individual charitable giving is the way to finance health care for everyone in this country. I think it's actually pretty tragic that we have people going to GoFundMe pages to get help, to get funding so they can pay for their child's cancer treatment. I think it's really tragic that we have to have something like remote area medical, RAM it's called, RAM clinics. That RAM was started as a charitable organization delivering health care in third world countries. But they discovered that we have the essentially the equivalent of that right here in Appalachia. And so just not very far from where I live in Nashville, in Wise, Virginia, just last weekend, they had a remote area medical clinic where people were lining up in cattle stalls to get free medical care. That's in the United States of America. I think that's shameful.
Couldn't those people get Medicaid?
No, they don't get Medicaid. They don't qualify for Medicaid.
How? Are they not poor enough? Please explain to me how these people don't qualify for Medicaid.
Medicaid is for people who are under 138% of poverty, and they have to meet certain criteria. If you are unmarried, you don't have children, or if you're a couple and you don't have children, you don't qualify for Medicaid.
Really? I've met plenty of people that qualify for Medicaid that don't have children.
Part of what the expansion of the Affordable Care Act was supposed to do is to allow people who had not previously qualified for Medicaid. It was supposed to then allow those people through the Medicaid expansion to qualify for Medicaid. But many states, like Tennessee, did not accept the Medicaid expansion. So we have hundreds of thousands of people.
So you're saying if you're unmarried, you do not qualify for Medicaid? If you do not have children, you do not qualify for Medicaid?
That is correct, unless you have some other condition. I mean, if you've got chronic renal disease and you're on dialysis, well, then you get Medicare.
Because I've met plenty of people that have Medicaid that are not married or do not have children.
Well, I think that you really need to do a little more research. There are many, many people who do not qualify for Medicaid, who do not qualify for any public assistance, and who don't have the wherewithal, the finances to purchase private insurance.
What about doing what other people do and use the emergency rooms?
Oh, that's a great idea. Gee, I hadn't thought of that.
What about it?
Really?
Tell me.
What about it? What about sending someone to an emergency room for a medical problem that could be treated by a primary care physician in a doctor's office, but you can't go to the doctor's office because you don't have the money to pay for it. So you go to the emergency room where the cost is astronomically higher
Yes.
And
So they said that costs of emergency room visits did raise the cost, but you think that somehow of these hundreds of thousands of uncompensated people going to emergency rooms will be cheaper or will be more expensive than providing single-payer care for the United States when projections on that in, say, California were supposed to cost twice the current annual California budget. In New York, it was supposed to cost 4 times the current annual New York budget. And in Vermont, it was supposed to cost 4 times the annual Vermont budget, so much where they had to pull out of it. Yet that, sending people to the emergency room would be more expensive than that on these rare cases where that occurs. Is that what you're telling me?
it's not rare occasions that that occurs. I was actually speaking with an emergency room physician yesterday who said that they're swamped with people using the emergency room as a primary care provider because they can't be turned away at the emergency room. But that is the most expensive
there's no doubt in that.
To deliver care. Let's talk about the cost. I know that they've been throwing around the number $32 trillion is what Bernie Sanders has been accused of costing. His single-payer plan over 10 years would cost $32 trillion a year. And that's a pretty big number, and I imagine it scares a lot of people to hear it. But what if I told you that without a single-payer national health program, we would spend $49 trillion. We will spend $49 trillion over the next 10 years. You know, we could save $17 trillion.
That's assuming something actually came in under budget, with I've never seen a large government program did. Medicare is well over budget. Medicaid is well over budget. The ACA, in terms of the results it's delivered per person, is well over budget. Why do you think it would actually stick to that number?
I'm only quoting the numbers that are out there that are put forth by the economists. And if we passed a national health program, the projected cost is $32 trillion.
So
now, any way you cut it, that's saving money. And the way it's saving money is by eliminating
specialists. You said it yourself. It's eliminating specialists. There's no way. You're telling me if I looked up all the insurance companies in this country, they make over $17 billion in profit, or 17. Well, what are the numbers? 17 trillion. So that's $1.7 trillion in profit per year. Because that's where that money would have to come from.
No, I did not say that.
Well, you said it comes from eliminating profit. That's where it'd have to come from. Because the government doesn't have any overhead that would.
Administrative waste.
The federal government doesn't have administrative waste? Who's going to pay your salary? Is it going to be the federal government providing you patients, or is it going to be individual payers? If I wanted to go see you, could I go see you under your plan?
With a national health program, what you would do in order to see a specialist is that you would go through your primary care provider and you would be referred to a specialist. That's how they do it very effectively in New Zealand, where I worked for a year.
That's great. Well, that's how they do it here in America right now. And in fact, I can do that, and I can usually see a specialist within a few weeks, whereas I know in some of the other countries I lived in, Japan, England, France, Venezuela, where my wife is from, it could take weeks, even months to see a specialist.
And you know how long it takes to see a specialist if you don't have health insurance and you don't qualify for Medicaid?
How long?
It takes a lifetime.
Oh. So it will be the same here. Look at the little boy in England who died because he wasn't able to get health care outside. Is that what we want for this country, where people cannot seek health options outside of the public delivery of that?
29,000 people are estimated to die annually in this country for no reason other than lack of access to health insurance.
Can you repeat that number for me?
So for the statistic is actually in the Annals of Internal Medicine, an article published last month by Dr. David Himmelstein and Dr. Steffi Wohlhandler. And they did a meta-analysis, which, if you don't understand what that is, that's looking at studies over the course of several years and putting all those statistics together. And what the results showed is that if the Better Care Reconciliation Act is passed, which it's not looking like it's
Oh, that's dead in the water.
Successful. But at one of the projections was 22 million people would lose insurance. And for that 22 million people who would lose insurance, it's estimated that 29,000 people annually would die a preventable death for no reason other than inability to access health insurance and therefore to access health care.
How many people
So
die?
we ration care in this country based on ability to pay.
How many people die in other countries waiting for health care, waiting for specialists, waiting for innovations that don't reach those countries because of nationalized health care?
No one dies in Canada or New Zealand
Really?
waiting
I bet you,
for an
Charles.
emergency life-saving
I'm not talking about life-saving.
procedure.
I'm talking about chronic care here. You said it yourself. Anyone can go to the emergency room anytime they want and can't be denied. So if someone needs an emergency life-saving procedure in this country, by your own admission, they can get it when they wish. However, it's the chronic procedures, the specialists, those are the areas where America overperforms other people. So in other countries where those specialists don't exist, you said it yourself, you want to ratchet down a number of specialists. Without those specialists, without the innovations that our medical innovation system brings, how many people will die in those other countries to give us an apples-to-apples comparison? Don't forget, America is also 5 times the size, I believe, of one of the next biggest industrialized country. I've looked into it. I can't find many other countries that I would certainly go to for healthcare that even come close to America size-wise. So even just in magnitude, if you're telling me...
Let me ask you, what is your goal here?
I'm just trying to find out...
Is it to say that we have the best healthcare system in the world? Because, again, if we look at public health statistics, unfortunately, we really don't.
Well, which public health statistics would those be?
Our infant mortality, our maternal mortality,
hang on a second.
Life expectancy.
First of all,
don't come even close
First
to
of all,
other countries.
Well, hang on. I've looked up life expectancy. We're in a year or two of most other countries, every one of which is considerably smaller than the United States. Number 2, we also have an infant mortality where we try to save children that are premature that are not counted infant mortality numbers in other countries that are counted in there. And number 3, you see rich people around the world come to America for health care. So it proves on the top end, we definitely have the best health care. On a GP system, maybe not. On a basic care system, if I have a cough and I need to take my son to the doctor, would I care if it's here or England or France or Japan or any other industrialized nation? No, we probably overpay. But in terms of getting those tough to reach cases, I have absolutely no doubt that the United States is the best healthcare system in the world.
Well, I guess I will agree with you that we have highly trained physicians who can provide incredibly phenomenal health care to people who can afford to pay for it. But if you can't afford to pay for it, then you are out of luck.
Isn't that true?
And unfortunately, all of those people get figured into our national statistics, and that's why our life expectancy and our infant mortality and our maternal mortality rates are so poor, because we have to include all of the people who don't get the care that they should, and that drags our numbers down.
Oh, I agree with that.
So yeah,
I absolutely agree with
if you can afford it, you can get great health care in this country.
But you don't think
And
providing...
if that's what you're championing, then I guess you and I just have to agree to disagree on what the goal is, what is our government's responsibility. But I will just point out to you that the AP poll just a week or two ago, when people were asked, is it the government's responsibility to assure that everyone gets health care, 62% of Americans said yes. So if that's the case, then the way to accomplish that is with the most conservative, responsible use of our tax dollars. And that is accomplished by simply pooling our resources into a single risk pool, distributing the risk, and providing health care for everyone. And we do that with a single-payer Medicare for All plan.
Carol, thanks so much. Enjoyed the back and forth.
You're welcome.
So there you have it, listeners. I just want to say that while I certainly come into these debates with my biases, opinions, and preferred positions, I try to remain as neutral as possible while hosting, keeping my mind open, but also probing into the positions of my guests, finding out how they think will work, questioning on the details, and letting my guests' opinions do the talking to you, the listeners, on whether their idea is the way to go. But one thing I cannot and will not stand for on this show is empty talking points, whether it's asserting opinion as common knowledge, or fact, or throwing out statistics and not being able to back up the context that they are used in. You will be questioned, pushed, and made to defend all aspects of your position, especially if it is pushing for a radical departure from the status quo. If that makes my show seem less balanced, well, so be it. It's my show. But I'm merely trying to present different policy positions and the problems with each, with the onus on the guests, not me, to convince our listeners. So if you liked it, didn't like it, think it was unfair, or think I pushed where I needed to push, please let me know. Did you agree with John Davidson that single payer is too expensive without delivering results we need? Or did you agree with Dr. Paris that single payer is better, cheaper, and more fair? You can do so by contacting me on Twitter, @DebatingHealth, liking and commenting on Debating Health on Facebook, checking out our website, www.debatinghealth.com, or emailing me directly, scott@ehrlichhealth.com. That's SCOTT @EHRLICH health.com. I look forward to hearing your comments. We'll make sure to respond to a few, as I'd love to debate you on our next edition of Debating Health. And remember, healthcare is complicated, so the best thing you can do is educate yourself. So do your own research, learn the issues, and take control of your own healthcare. Till next time, I'm Scott Ehrlich for Debating Health.
Doctor, please, don't you know I'm going